Good afternoon, and thanks to SAGES and to the moderators for inviting me to be part of this very exciting debate. And I was very excited to see that 0% of people chose the bypass for this patient, but hopefully your opinions will change after this talk. So to start, I have no disclosures. I do, however, have a disclaimer that as a surgeon who's arguing for the gastric bypass side, that the views, thoughts, and opinions expressed in this talk do not necessarily reflect the clinical practice patterns of this speaker. So the answer to this debate, gastric bypass versus sleeve, in my opinion, is very simple. We all strive to practice evidence-based medicine, so the answer is really in what is the evidence out there in the adolescent bariatric literature. And while, as Dr. Berzoni pointed out, there's a lot of information in the adult literature, we have to remember that pediatric patients are not just small adults. And if there's one thing I remember from my pediatric surgery rotation, it was that statement. So the real question is, what quality data is available in adolescent bariatric surgery? And if you look at the literature, you'll find that there are very few studies. They're all very small numbers, heterogeneous study design, heterogeneous data endpoints. Many are retrospective or purely observational. They all are relatively short to midterm follow-up. Most do not evaluate 2 or more surgery types, so it's hard to even compare the 2 operations. And the longest term data is actually based largely on lap band results because that used to be the operation of choice in this patient population. Given this, in this debate, while I admire Dr. Berzoni's valiant efforts at defending the sleeve gastrectomy, I would argue that the last 8 minutes were based largely in conjecture, partial truths, and dare I say, some fake news. And given the fact that there is no good data on this topic, and the absence of that type of data, then the Roux-en-Y gastric bypass is and has been the gold standard for morbid obesity treatment, and I've won the debate. Now, I still have a few minutes left, and I thought it'd be unfair to win the debate so easily, so I thought that I would share some more of the studies and their results in order to further bolster my side of the argument. Starting with a teen lab study 3 years out, as Dr. Berzoni showed, I guess the data is all in how you interpret it. If you look at this data, the way I look at it is that the bypass outperformed the sleeve, both in weight change from baseline as well as improvement in dyslipidemia. Now, this study was not actually designed to compare the 2 operations, but this one, also one that Dr. Berzoni put up, was designed. It was a retrospective study looking at electronic medical records. But in this one, again, the Roux-en-Y gastric bypass outperformed the sleeve in the short term. So what about longer term studies? This is the Amos Swedish study, where 3 cohorts of patients were compared. This was adolescent patients that underwent Roux-en-Y gastric bypass, a control adolescent group that underwent non-surgical intervention, as well as an adult control group. And as you can see here, this is the loss in BMI. The patients, the adolescents who underwent surgery, the bypass, had better results than those who did not, and in fact, better results than in the adults. This study showed substantial weight loss, frequent resolution of cardiometabolic comorbidities, as well as improved quality of life. In another 5-year and longer study, the FABS 5+, a prospective follow-up of a group of patients who underwent Roux-en-Y gastric bypass. They followed these patients for 5 to 12 years, and again, demonstration of major and sustained reductions in BMI and substantial improvements in cardiometabolic health. They also noticed, interestingly, a floor effect where patients with higher BMIs did not do as well as patients with more moderate BMIs, underscoring the importance of performing these operations earlier on. As with everything, we have to weigh the benefits versus the risks. And while those studies did show benefits of the bypass, there are obviously risks to the Roux-en-Y gastric bypass that might be a little bit higher than the sleeve, which include reoperations as well as nutritional deficiencies. But studies have suggested that there are ways to lower these complication rates. For example, a lot of these reoperations have to do with the internal hernias, so there are ways to close the mesenteric defects, or the use of ursodeoxycholic acid to decrease the number of gallbladders that have to be resected afterwards, as well as more vigilant programs to increase postoperative adherence to vitamins, especially in this adolescent bariatric population. If we look at some of the systematic reviews and meta-analyses in the short term, midterm, and long term, and this is an example of each of those, these studies all demonstrate that the gastric bypass results in excellent sustained weight loss, significant resolution of comorbidities, and a significantly improved quality of life. What's really interesting if you read these studies is that they all spend a large portion of their discussion and conclusions discussing the limitations of the evidence in the literature, stating that all of these studies lack statistical power, that the attrition rate affects the ability to determine true weight loss over time, long-term data is scarce. In one of the meta-analyses, there was only one sleeve study with an over 5-year follow-up, and the general poor quality of evidence for reporting of comorbidity resolution and complications. I think it's also important to note the changing landscape of adolescent bariatric surgery, which very much mirrors the adult trends. And as you can see here, that line that's rising over to the right side, that's the rise in sleeves and a subsequent drop in the number of bypasses being performed. The real answer to this debate will be when this cohort of patients is followed out for the long term, and not until then will we really have a true answer to which operation is best. So in the end, there is no universal answer based on the evidence of Roux-en-Y gastric bypass versus sleeve. I think for now we need to take each case on a case-by-case basis. We need large, well-designed long-term studies to specifically evaluate bypass versus sleeve, which we do not have yet. I think it's important to know when the bypass is indicated, and so this is likely in when we need more durable weight loss results, when patients have greater comorbidities, and when we do not want the risk of reoperation. So in this debate, I wanted to conclude with just a few excerpts from some of these studies. Bariatric surgery in adolescents results in similar short-term weight outcomes to adults, with the Roux-en-Y gastric bypass producing the greatest weight loss with the most robust evidence base. We can skim through this, but the vertical sleeve gastrectomy is the only irreversible procedure, so this needs to be weighed in when we're looking at benefits versus risks. Furthermore, a greater proportion of bypass than sleeve patients in this study achieved 30% weight loss, suggesting that bypass may be a superior procedure for patients with the most severe levels of obesity. And finally, wait for it, the ASMBS Pediatric Metabolic and Bariatric Surgery Guidelines, of which my opponent was a co-author. I will end with this slide. We still lack significant long-term outcomes data on sleeve and should remember that the bypass remains a safe and effective operation with significant long-term outcomes data. I did not write that. Thank you.